Hello and welcome back. This is going to be the third video in the general discussion on an approach to rash, and today I'll be discussing interface dermatitis. And interface dermatitis will be discussed under the following general top headings. First, we'll define what is interface dermatitis and understand when it is to be clinically suspected. Okay. Second, we're going to establish the no eosinophils rule and understand the prerequisites needed for interface dermatitis to satisfy it. Then we'll use the no eosinophil rules to classify the disorders that are clubbed under the histological spectrum of interface dermatitis. And finally, we'll understand the two basic immunological mechanisms that result in interface dermatitis. In the process, classifying these disorders the way I like to classify it. So that need not per se, to what is there in dermatology literature, but clinically that is what I use, and I found it to quite useful. Okay, so what is interface dermatitis? Interface dermatitis is a broad histological term that is used to define or describe immunologically mediated skin disorders that damage the dermo-epidermal junction. Okay, and histologically it is classified into two broad buckets. The first one being vacuolar, and the second being your lichenoid. Now please remember, this is lichenoid, not, this nothing to do with lichenification. Okay, so lichenoid is a it's a broad band of inflammatory cells that have infiltrated into the superficial dermis right next to the epidermis, whereas lichenification is accelerated or accentuated differentiation of the epidermal cells in the epidermis. So those are two distinct things. I've discussed this in our first discussion in detail. Okay, now when does one suspect this clinically? So obviously dermo-epidermal junction would be right next to the epidermis, so this would be a very well demarcated lesion. The second thing is the color. The color would depend on whether there is lichenification or not, as in, is the immunologist causing the epidermal cells to undergo accentuated premature differentiation or not. Okay, if it is not causing it, then obviously this being such a superficial lesion would have a significantly erythematous component. Whereas if there is lichenification, the epidermis overlying this lesion would become very thick, and obviously light that is incident on the lesion would then have to pass through more of the epidermis to reach the examiner's eye, increasing the amount of Rayleigh scattering. Therefore, the lesion would become violaceous. Naturally, also there would be some thickening. Okay. Now, please remember, lichenification is not the same as a lichenoid dermatitis. Lichenoid is a histological term. Lichenification is essentially the thickening and of the epidermis in response to some kind of immunological process or recurrent trauma, resulting from premature differentiation, accentuated differentiation of epidermal cells as they go from the the stratum basale to the stratum corneum. Okay, so now we come to the no eosinophils rule. So the no eosinophils rule is as follows. Okay, if you have a relatively non-acute cutaneous response to interferon alpha or beta, okay, production locally, that characterizes what we had described as psoriasiform disorders. Okay, psoriasiform dermatitis. These were the these were the group of dermatitis that did not show a normal epidermal maturation. Okay, which was in stark contrast to what we found in cases of lichenification. Now, this was not impaired maturation because the rate of cellular proliferation was too high. It was actually a primary problem in the maturation or the differentiation of cells from the stratum basal to the stratum corneum. Okay, now if such a process is occurring, such dermatitis do not affect the barrier function of the skin unless they are very severe, right? So there is impaired maturation, okay, but whatever skin has already been synthesized prior to this is still going to be effectively remain the same, so it's not going to affect the barrier function of the skin primarily. So if the barrier function is not affected, okay, and this is very important, this obviously will be the case if there is not that florid in inflammation, but provided that those two criteria are met, then the T cell Th2 polarization will not occur. We remember from our discussion on eczemas in the previous discussion, Th2 polarization happens when the epithelial barrier function is defective, and because of that exogenous peptides are able to reach through the epidermis into the dermis, resulting in epidermal cell production of thymic stromal lymphopoietin. Okay, and that obviously will not happen here, and therefore Th2 polarization will not occur, and Th2 polarization doesn't occur, your Th2 cells will not be there, so they will not be able to produce interleukin 5, therefore eosinophils will not come into the lesion. Okay, so this is clear till now, and then finally this brings us to the no eosinophils rule. So for a lesion to satisfy the no eosinophils rule, the pathogenesis resulting in the lesion should not disrupt the barrier function of the skin. So the no eosinophils rule is followed by any pathology that does not disrupt the barrier function of the skin. Okay, this would include the following. Okay, so it would include, first and very importantly, the alpha interferonopathies, for example, are SLE. Okay, but they should not be very severe. If they are too severe, they will cause skin damage, and that skin obviously will then have a impaired barrier function. The second type of pathology that might present like this is any disorder which has significant lichenification. Okay, because lichenification by definition is a exaggerated thickening and differentiation of epidermal cells, and again this depends, there should not be much of an inflammatory component in this process. Okay, so these are the two broad types of disorders that can result in patient the barrier function of the skin being preserved in spite of such an inflammatory skin process happening. Okay, now what I do clinically is I classify these disorders, the interface dermatitis, into 4 classes based on whether or not they satisfy the no eosinophil rule. The no eosinophil rule has been defined as there should not be any that there should not be, okay, and there should be no more than one eosinophil, okay, found on assessment of up to 20 up to more than equal to, or at least rather 10 20x power fields. Okay, so this dermatopathologist has to do, but for the purpose of understanding the we need to actually build our understanding from the level of dermatopathology. So this is the no eosinophils rule. Now lichenification, as I have already described, is a thickening of the epidermis. The thickening of such a thickening of the epidermis is the result of what? It is the result of premature basal epidermal cell differentiation, excess differentiation, and therefore resultant acanthosis or thickening of the skin. Okay, so the lesions that come under this category include, so if both the no eosinophils rules is satisfied and you have a lichenification, then what we have is actually either lichen planus or a skin specific disorder known as pityriasis lichenoides et varioliform acuta. Okay, so it's a Latin word. Doesn't really matter from a clinical medicine perspective, but that spectrum of disorders. Okay, now these lesions are both lichenoid. They have these lesions are both have lichenification by definition. So the skin barrier function is intact, hence they do not follow the no eosinophils rule. Okay, now on the other hand, you could have disorders such as SLE, where there is interferon production, and that interferon production is what is causing impaired differentiation of the basal epidermal cells. But because the already synthesized skin is relatively intact, and also there is slow differentiation but not actually significant disruption of the skin barrier function, you still have a preservation of the no-eosinophils, or they stick to the no-eosinophils rule. Okay, now disorders that do not fit the no-eosinophils rules are just the same, like disorders with lichenification, but either disorders that are very florid or they are very acute. Okay, so this would include your lichen keratosis, lichenoid pigmented purpura, lichenoid mucosis fungoides, and a lichenoid drug eruption. Now this and keratosis we will not be discussing because I am a dermatologist and it is not particularly relevant to us in internal medicine. However, we will be discussing the disorders, the other disorders in this list. Okay, and finally we have erythema multiforme and your viral exanthem. Now see, a viral exanthem is also a type 1 interferon response of the skin. Now please remember, a type 1 interferon response of the skin when very acute or florid, as would happen with an infection, can break the no-eosinophils rules. That is why it is under this category. Okay, similarly erythema multiforme when very severe. So erythema multiforme minor is actually follows the no-eosinophils rule, whereas it is when it is very severe, that is when you have SJS. Okay, that point of time it starts not following the no-eosinophils rules. It starts breaking the no-eosinophils rule, and that is your that is what we'll understand. We've understood from this table. Okay, so let's just discuss these disorders in detail. As I have just discussed, these are the now GVHD, erythema multiforme, and syphilis are not alpha interferonopathies, but they also do not disrupt the epithelial barrier function. Then they are not so when they are not acute, they also follow the no-eosinophils rule. Now erythema multiforme being very severe and very acute breaks the no-eosinophils rule. Now viral exanthems, like I've just discussed, are naturally mediated by type 1 interferon release, and that is the literal function of alpha and beta interferon, and therefore they will not however they are very severe and acute, so they break the no-eosinophils rule. Okay, now since we've divided these disorders into these 4 subclasses, we'll follow through and discuss each of the subclasses. So lesions that follow the no-eosinophils rule and show lichenification would be these 2 disorders. Okay, so let's see what happens here. So lichen planus we've already discussed is a specific anti-keratinocyte Th1 polarized response producing interferon gamma that causes CD8 plus T cells that are the anti-keratinocyte to get activated. Those cells attack the cells in the stratum basal of the epidermis, and that causes loss of those cells, loss of the stratum basal cells, and that results in the space that is left there results in fluid accumulation in that area, and that is results in the development of fluid-filled vacuoles at the dermoepidermal junction and actually eventual complete obscurement of the dermoepidermal junction. Now this actually, that the fact that the dermoepidermal junction is obscured is the histological definition of interface dermatitis. Okay, but again, since we are not histopathologists, that is not where we will diagnose it. We will try to strongly suspect at least such a disorder prior to this eventuality. So like I discussed with lichen planus, the growth rates are lower than normal, differentiation is accentuated, so because of that you end up getting a very thick and very thick granular cell layer, often forming wedges. Okay, so this is the pattern that develops. There is a superficial subepidermal band like infiltrate of predominantly blue of basophilic cells, which are obviously likely lymphocytes. The general pattern of the dermoepidermal junction is still visible, but actually it is not very clear, it is getting obscured. Okay, and if you take a more enhanced view, you find that there is a increase in the number of or the size of the granule cell layer of the epidermis. Okay, so that is there, and this is what the lesion would therefore look like. Because it is quite superficial, it will be well demarcated. As it is well demarcated, but wherever there is epidermal thickening in those areas, Rayleigh scattering will occur more than normal. So because Rayleigh scattering will occur, the lesion will stop looking red and will start looking more and more violaceous or slightly gray. Okay, and that is what we're seeing here. So this is your classic lichen planus. Now on the other hand, in the PLEVA PLC spectrum, you have basically it's very similar to your alpha interferonopathies. Okay, there is dermal plasmacytoid dendritic cells that are producing type 1 interferon alpha and beta, and that impairs keratinocyte maturation. Okay, and when that happens, a prolonged exposure induces basal epidermal cell apoptosis and or necroptosis, and then the spaces that are left, fluid accumulates. Okay, so again you can see it is similar to what you saw on this side in the lichen planus spectrum, but much fewer number of these lymphocytes have infiltrated the superficial dermis, and there appears to be some RBCs leaking into the epidermis. Now if you look carefully, there are small holes present at the dermoepidermal junction. Okay, there are small holes that are present at the dermoepidermal junction. These are the holes. Okay, and this is the pathognomic finding in vacuolar interface dermatitis. Although here there is some lichenification. So the lesions look like this, again well demarcated, but because there is lichenification, again they are not red, they are violaceous. Okay, because that lichenified skin essentially enables Rayleigh scattering to occur, and therefore the red components of the light are scattered away. Now second, we'll talk about lesions that follow the Noy-Snuffel's rule and do not show lichenification. So what these lesions are your erythema multiforme and your polygenic alpha interferonopathies. Now this is actually the most important subsection of these disorders from an internal medicine or rheumatology perspective. Now erythema multiforme, so why I have not included GVHD and syphilis in this category is because graft versus host disease occurs in a very specific context, and there is usually, by the time the patient comes to you, there is significant dermal fibrosis, so it looks very similar to and is a mimic of systemic sclerosis, and we'll be discussing it under that category. The syphilis essentially can look like anything, so there's no point in really discussing each individual variation of cutaneous manifestations of syphilis. So we'll restrict our discussion to these two entities. Again, erythema multiforme, there is a Th1 polarized response, interferon gamma is produced, this activates CD8 plus T cells, this causes necrosis, or the CD8 plus T cells go and kill the basal epidermal cells, that causes constant necrosis of these basal epidermal cells, and this is what we see. Okay, so what you find is these lymphocytes infiltrating into the superficial dermis. Okay, they seem to be causing some degree of necrosis here. There are some red, very dense red marks that you can see. These are called dead reds. Okay, colloquially, these are basically necrotic keratinocytes, and there are fluid-filled vacuolar spaces forming at the dermoepidermal junction, and though that is what what happens in erythema multiforme. Okay, now clinically, when you look at the lesion, because there is no significant lichenification that has occurred here, the lesions still look reddish or erythematous. Okay, now an happening over here is that where the lesion is the most severe, that is right in the center, there is so much necrosis that the lesion is almost starting to look blackish in color. Okay, so that is why we get that typical targetoid look appearance here like this. Okay, so that is your targetoid appearance of erythema multiforme. It need not always be so obvious, but yeah, it is. This is what erythema multiforme looks like. Now, on the other hand, in case of SLE and dermatomyositis lesions, this specifically I've taken subacute lesions because acute lesions would damage the skin barrier function so much that you might end up getting breaking the nose to film. Okay, so here what you find is something interesting. There is some perivascular lymphocytic infiltrate. You have some subepidermal lymphocytic infiltrate, but not very significant subepidermal infiltrate. You wouldn't call it lichenoid. Then also I can't decide where the dermoepidermal junction is. So this is not really the dermoepidermal junction. Okay, this is this is technically the dermoepidermal junction, but what you can see is that in parts it is not confluent. There are some holes, white dots that are dotting this dermoepidermal junction, and that is what we call vacuolar interface dermatitis. Now, what has happened here is there is a plasmacytoid dendritic cell somewhere here that is producing type 1 interferon. That type 1 interferon is impairing epidermal cell differentiation. Okay, now because the epidermal cells are differentiating very slowly, the epidermal thickness has decreased, so that the thickness of the epidermis is very less. Okay, and even in the stratum corneum you find some nucleated keratinocytes, and that is what we call parakeratosis. So this is a rather interesting presentation if you think about it. And there's actually some mucin also here in the superficial dermis, and we'll talk about that at a later date. So this is what we find in your SLE and dermatomyositis, subacute lesions of SLE and dermatomyositis. Okay, now again this is a magnified view from a different patient, and again you see these dots or these holes present at the dermoepidermal junction. Okay, in this particular case you don't find any, maybe this is a necrotic keratinocyte, but not very significant number of dead reds. And clinically what would this look like? Again, very well demarcated, thinned skin. Okay, because the epidermis is actually thinning, it's not thickened like in psoriasis, okay, or in lichenification. Very well demarcated, and again because the Rayleigh scattering will not occur because superficial to the lesion the epidermis is actually thinner than expected, you get a erythematous or reddish lesion. Okay, so this is what you end up getting. Now, third category is lesions that don't follow the no-eosinophils rule and do not show any lichenification. So that is these disorders. Now that is these disorders, that is erythema multiforme major and viral exanthems. So what do they look like? Now what you see, this is very similar to what we saw with erythema multiforme minor, but here there is so much confluent necrosis of the epidermis that the epidermis is actually separated from the dermis. So that's a very severe lesion. Okay, and clinically this looks like for example, the mucosa, if it is affected, the mucosa essentially separates from the underlying dermis, and there is a loss of mucosal continuity. Now, the lesions in this particular case look very similar to what we found with multiforme, but you can see that the center of the lesion now start to leak fluid from the epidermis into the subepidermal junction and starting to form bullae, and these bullae will eventually desquamate. And finally, like I said, that skin will come off, or the mucous membrane will come off, and that will leave these deep ulcers. Okay. Now, in case of a drug or a viral exanthem, the process is still the same as what we saw with subacute SLE or dermatomyositis. However, the process is much more florid and acute. Okay, so again you see these holes. Okay, and actually these holes, some of these holes contain lymphocytes. There some holes don't, some holes do. Okay, and it looks like this. It looks like looks very similar to your subacute cutaneous LE or this thing. Okay, so that's your these are the two ends of the spectrum of interface dermatitis, pathophysiologically speaking. Okay, so one end is Th1 polarization with secondary activation of secondary production of interferon gamma, resulting in activation of CD8 plus T cells, which then damage the basal epidermal cells. And the other end is your local production of type 1 interferon, which impairs epidermal maturation, resulting in a thinned out epidermis. Now in the first category, because there is thickening of the epidermis, because there is a lichenification of the epidermis, if the process is slow enough, you may get lichenification. Okay, and that would follow the no eosinophils rule. In the latter category, you have a very you have interferon production. Type 1 interferon production doesn't really damage the epithelial barrier function as much, so you essentially don't need to, it should satisfy the no eosinophils rule unless the disorder is very very florid and it is damaging the contiguity or the integrity of the derm-epidermal junction. Okay, now finally we come to the last category, that is lesions that follow the no eosinophils rule but that don't follow the no eosinophils rule, or they and show some lichenification. So they don't follow. Okay, that would be these disorders. So like I said, lichen keratosis and lichenoid pigmented purpura I will not be discussing because they are not they are primary skin disorders. Lichenoid mycosis fungoides is something that we need to discuss because it's a cutaneous lymphoma, and lichenoid drug eruptions are common differential in patients that come to us. So we'll discuss these two disorders. So here I'm going to go slightly opposite. Okay, this is a repetitive example. So what would you talk about? How would you describe this lesion? So this is actually in parts relatively well demarcated. So this particular area of the lesion is well demarcated. Maybe you could say this area is also well demarcated, but parts of the lesion are definitely showing poor demarcation. Okay, there is a zone of transition where the lesion is where the lesion stops and where normal skin starts, you can't really tell. Okay, so there is a portion of the lesion that is showing it's not very clearly demarcated. Then there is a heterogeneity in the lesion's color. Okay, there are some parts of the lesion, particularly the well demarcated ones, where the lesion is red. Okay, but in other areas where the lesion is not well demarcated, there it is starting to become brownish or violaceous. So why would that be? It probably implies that here whatever process is happening is quite superficial, and in other areas, that is here, the process is extending deeper into the dermis, and therefore is the light that is reflected off it is undergoing Rayleigh scattering. Okay. So essentially in lichenoid mycosis fungoides, what happens is a neoplastic effector memory T cell clone. So we'll discuss what effector memory T cells are. That is derived from usually resident, sometimes migratory memory T cells, undergoes a point mutation resulting in a neoplastic conversion. Now mycosis fungoides is actually notorious for having very different lesions, different tumors having very different mutational landscapes, and so that is good in a way because then we don't have to remember all of them. But they show two very common features. One is there is epidermotopism, that is the neoplastic lesions localized to the epidermis. Second is there is lymphocytic exocytosis. Now what that means is that those dermoepidermal holes that were forming, that are characteristic of interface dermatitis, those holes, almost all of them are filled with lymphocytes, because there obviously it is the lymphocytes, the neoplastic lymphocytes, that are causing the death of the keratinocyte, and therefore you will find it, you will find the killer right next to the killed keratinocyte. Now histologically this looks as you would expect it to look. Okay, so that is superficial dermis, there is a lymphocytic infiltrate. Okay, so technically this is a lichenoid dermatitis. What you find is the dermoepidermal junction is relatively obscured, it's not very clear, compared to normal skin. And when you take a deeper look, what you find is that there are some interface holes, and many of those holes are filled with lymphocytes. These lymphocytes don't look normal. Okay, what you find is that the nuclear chromatin is very dense. It's very densely basophilic and showing various mitotic forms. So these are obviously neoplastic. This is a feature of neoplastic lymphocytes. Now, on the other hand, in lichenoid drug eruption, you found what we found earlier was a relatively, again, not a very well demarcated lesion, center of the lesion showing slight erythema and surrounding areas showing slightly brownish to violaceous discoloration, indicating that the lesion at the sides is actually extending deeper than you would expect it to extend. Okay, so correspondingly in the histopathological section, what you find is that there is a dense lichenoid infiltrate. Again, this is not lichenification because the epidermis is not lichenified. The interface the lymphocytic infiltration is lichenoid, as in there is a dense band of lymphocytes just below the epidermis. And you find these holes that are there in the junction, and that is why it is an interface dermatitis. But what you also find is these densely red red granule containing cells, and those are obviously eosinophils. Okay, so orange to red granule containing cells or eosinophils, you find some of them in the dermis as well. Okay, here, and that obviously indicates to us that a drug is responsible. So that is your lichenoid drug eruption. Again, both of these entities are types of interface dermatitis that show significant lichenoid infiltrate but no lichenification. But in lichen planus, you find a lichenoid infiltrate, you have interface dermatitis, so the dermoepidermal junction is no longer intact and there are holes there, and there is often lichenification. Okay, so the clinically they don't show these two don't show lichenification, but they show lichenoid infiltrate in the superficial dermis. So I hope that differentiation is very clear. The terminology admittedly is confusing. It should not be confusing by now. Okay. So now in this discussion, I have discussed the following. I have defined interface dermatitis. Okay, we've understood that it is a dermatitis primarily affecting the dermoepidermal junction, usually resulting in the development of fluid-filled vesicles at the dermoepidermal junction. If that is all you see, that would be vacuolar. If you see a lichenoid infiltrate in the superficial dermis, that would then be a lichenoid interface dermatitis. And we've understood that well demarcated lesions without significant lichenification or epidermal changes would constitute your, or the lesions that show epidermal thinning would constitute your lesions that could be interface dermatitis. Okay. Second, we have established what the no eosinophils rule is. In order to satisfy the no eosinophils rule, a lesion must allow the skin to remain intact, the barrier function of the skin to remain intact. Therefore, it can either be due to local type 1 interferon production or type 2 interferon production, but in neither of the two cases should the process be too florid or too too damaging, because if it damages the skin, then the no eosinophil rule breaks down. I have then used the no eosinophils rules to classify these disorders that are clubbed in dermatopathology under the heading of the interface dermatitis into 4 separate subgroups. Okay, and this is for primarily 2 reasons. One is lichenification is something you can pick up clinically. Okay, so if you have significant lichenification clinically, and then there are no eosinophils on the biopsy, okay, or you have significant lichenification and then there are eosinophils on the biopsy, that allows clear differentiation. Okay, and as we will go into the next 2 videos in the series, we'll see that other superficial dermal disorders are slightly different, and they don't induce this kind of epidermal changes we've been discussing as of now. Okay. So that'll fit into the entire. We'll make a large algorithm for well demarcated superficial epidermal, dermoepidermal junction, and superficial dermal, and how to approach them clinically. Finally, we've understood the two basic immunological mechanisms that result in interface dermatitis, being obviously the production Th1 polarization with production of type 1 interferon, Th1 polarization with production of type or interferon gamma, type 2 interferon, and secondary activation of CD8 plus T cells that damages the basal epidermal cells, resulting in confluent necrosis. That the prototype of that being erythema multiforme. And when it is not acute, that follows the Loeys-Snuffel's rules and doesn't show lichenification. On the other end of the spectrum, we've got your SLE and dermatomyositis and other alpha interferonopathies, where plasmacytoid dendritic cells or other local cells in the vicinity of the epidermis produce type 1 interferon alpha and beta, and that impairs epidermal maturation. That impaired epidermal maturation doesn't really have an effect on the the barrier function of the skin. Therefore, the barrier function remains intact, so there are no eosinophils, so it follows the no eosinophil rule, but there is no lichenification. Okay, because obviously the reverse of that is happening, that is, there is epidermal thinning. So that brings us to the end of this discussion. Thank you, and I'll see you in the next video.